You know, you're in West Virginia. We're #1 in the nation in diabetes. It's a real problem because historically, West Virginians are, you know, they're going to eat whatever they happen to have on hand. And so their eating habits aren't too good. And on top of that, it's passed down from generation to generation. So if you're going to cook beans, you might as well throw some bacon in there. And
well, I've seen so many people, they had diabetes, lost their legs. My mother was a diabetic, my grandma was a real bad diabetic, she died of coma. My uncle diabetic. Is just, you know, all around. And
it is the largest free clinic in the state. We see 20+ thousand a year here. The largest bulk of our population is working poor. People that work, you know, maybe fast food, etc., that, you know, can't access care. A good example would be like, you know, a waitress or your local Walmart worker. A lot of these places offer medical benefits, but the price is so high that they can't afford it, you know, in a minimum wage job.
But we've had patients come in and they don't know how to get the insulin out of the vial, or they're used to, because they don't have money and medications are expensive, they'll, you know, cut their pills in quarters and take a quarter of a pill rather than the whole pill, and they think that that's okay to do.
There's a lot to do with Appalachian culture and trust issues in terms of trusting a provider.
They really need to get family and friends educated and to get them on board, because we can teach them and give them information until the cow comes home. But if you walk out this door and your husband says, well, I'm hungry, I've been down here all day with you, let's just stop at McDonald's and eat.
And we have areas that are what you call up a holler, where, you know, there's nobody. There's no access, there's no in and out, people don't have a car, they might come out once a month to get, you know, groceries or whatever, or somebody might bring them to them. We get, like, their main number, a second number, you know, contact number, and a contact number, because we usually will go through 3 or 4 before we can get them, because typically, you know, they've lost service.
They do what they do to get by, and a lot of times it means if you're want to pay for food versus medicines, the medicines lose out.
And we try to put all their visits together as much as possible. So, you know, you may come here and one day see a provider, get your medications, go to the dental chair and get an extraction, have a GYN visit and see the cardiologist all on the same day, plus go to a diabetes class.
We have seen about a 20% drop in hemoglobin A1Cs, which is pretty phenomenal.
But when I went to my last doctor, they took me off my Lasix, my potassium, cut my thyroid in half, pill in half. So everybody's just done one.
But I just think the way they do things is just real enriching for everybody, you know. And they have to feel good about themselves because they help so many people.
My ultimate goal is that every single person involved in Project Impact gets everything that they need, including medicine, and understands how to navigate the system if we're not here.
I want to be off the medicine. I want to have, like, lost 50 pounds. I really would. If I could just get to where I felt better.
Yeah, this is going to be a big quantum leap for us, and I think it's going to produce better outcomes for the patients to be able to marriage the clinical pharmacist right into our system of care here. They're going to have access to our electronic medical record and the Project Impact database. Work with the patient, having them bring their medicine in, talk to them about using the test, which I'm really thrilled with, so that they absolutely are teaching from the point that the patient's starting at.